Welcome, and thank you for joining us today. My name is Ellen Wilson, and I'll be the moderator for this expert briefing for the media, which is hosted by the Johns Hopkins Bloomberg School of Public Health. Today's experts will discuss the risks, rising cases, and protective measures against various infectious diseases, including seasonal influenza, COVID-19, mpox, avian flu, and parvovirus. I'd like to briefly introduce our speakers. Andrew Pekosz is a professor and vice chair of the Department of Molecular Microbiology and Immunology at the Johns Hopkins Bloomberg School of Public Health. Kari Debbink is an associate teaching professor in the Department of Molecular Microbiology and Immunology at the Johns Hopkins Bloomberg School of Public Health. We will have time for questions following our speakers' remarks. We will take some that have been submitted in advance of the briefing and some from the Zoom chat. If you have a question, please enter it in the Zoom chat addressed to panelists and hosts. Please enter your name, media outlet, and question. We hope to cover as many as possible. Please note that participants are welcome to use images, video, or quotes directly from the briefing, and that the content is for immediate release. Participants will be muted during this briefing and it will be recorded. Dr. Pekosz, please tell us where we stand right now with the virus infections we expect to see during the fall and winter seasons.
For COVID-19, we just saw a summer that had a rather large surge of cases. In the past few years, we have seen summer surges of COVID, but this one was a bit larger than we would have expected. COVID cases have plateaued or are going down across the US and globally as well, but we do expect another surge of cases sometime around the new year. We expect to see cases of respiratory syncytial virus, or RSV, start to appear soon, primarily in children and in individuals over the age of 65. Around November, we should start to see cases of flu across the US. The Southern Hemisphere just had their winter season, and two of the three flu viruses, ones we call H1N1 and H3N2, were causing cases there. But the overall activity was considered normal. The H3N2 flu virus circulating in the Southern Hemisphere has changed or mutated in a way that may make it less of a match to the current influenza vaccine here in the Northern Hemisphere. Public health officials will keep their eyes on H3N2 activity, in particular in the Northern Hemisphere. This doesn't have any effect on vaccine recommendations because the vaccine is already on the shelves of pharmacies.
Great, thank you, Dr. Pekosz. Dr. Debbink, with the reemergence of infectious diseases such as mpox, please tell us about this disease and what we're seeing with the current outbreak.
Sure. Mpox is a disease caused by a virus, and it is transmitted by close contact with infected people. This could be by close physical contact, sexual contact, or contact with things like bed sheets, blankets, clothing that an infected person has worn. The main symptoms that are associated with mpox would be fever, fatigue, swollen lymph nodes, and then the characteristic rash that turns into blisters before scabbing over and healing. In rare cases, particularly in children and in those with immunodeficiencies, mpox can be fatal. In terms of what we're seeing here in the United States, our first mpox outbreak was in 2022, and during that time, we had around 33,000 cases of mpox here in the United States. Since then, we've seen a much lower rate, so maybe 1,000 or 2,000 cases per year in the last 2 years. And a big part of that was due to the US developing a really good surveillance and action plan for mpox. For instance, we have the ability to do wastewater surveillance for mpox, so we can figure out where it is and when it is. We also have really good testing for the clinic, so when people come in with symptoms that are associated with mpox, it can be accurately tested very quickly. And then we also have vaccines that can prevent it. And so for those in high risk groups, high risk for contracting or being exposed to mpox, they're able to get the vaccine. So in terms of the United States, we have a really nice infrastructure right now for mpox. Globally, the reason that we are seeing mpox right now in the news is because there is a different type of mpox than the one that is currently here in the United States. And this different type of mpox has historically been associated with higher rates of severe disease and mortality. And while it was previously really found in only a few countries, it is now spreading. And so the World Health Organization in August put out basically an alert that this is a problem that all of us have to deal with around the globe. And so by putting out that public health emergency of international concern, it's basically alerting the global community that they need to help in the effort to control mpox in the countries where it currently is. And this is for a couple of reasons. One, we want to reduce the disease burden in those countries. And we also want to prevent the spread to other countries. So right now, the global health communities need to be involved in those efforts. Currently in the United States, we have not seen any cases of this new mpox. However, like I said, we are really well prepared for identifying those cases and then preventing spread within the country.
Thank you, Dr. Debbink. Now we will take questions. Again, a reminder, if you have a question, please enter it in the Zoom chat with your name, media outlet, question, and to whom you'd like to address your question. We'll take the question from Alexandra Pecci at Pharma Voice for Dr. Pekosz. How is vaccine treatment development keeping up with the H5N1 threat, and would it be sufficient for a pandemic or broader outbreak?
Yeah, an important question. So we've had avian influenza, more specifically called H5N1 infections that have spread to most recently dairy cows here in the United States. It's also resulted in about 14 cases of infection of humans. H5N1 is a avian virus that we've kept our eye on for many years now, as it has the potential to cause a pandemic in humans. There has been some preparation already that's been done in terms of choosing vaccine strains that match the H5N1, growing them up, generating stocks that we could more rapidly increase our amount of so that we could begin a distribution pathway. None of that is really in place yet because the risk to the general public is still considered low, but there is a good deal of preparation that has gone in for H5N1 vaccines. We also know that influenza antivirals will work against the H5N1 strains in dairy cows right now. So it's a concerning situation to public health officials, but we are certainly in a better place with H5N1 than we were at the beginning of the COVID-19 pandemic, where we really had no antivirals, no vaccines, and very few diagnostic tests that were able to detect that virus when it first entered the human population.
Great, thank you. Here's a question from Nick Iannelli at WTOP for you again, Dr. Pekosz. You mentioned COVID cases were higher than expected in the summer. Any idea why that was, and why are you expecting another surge in the near future?
There's probably a few reasons driving our summer surge of COVID cases. One is, a variant, the JN.1 family of COVID variants had emerged a few months prior to the summer, and they had a large set of mutations that looked very different from previous variants that were circulating in the human population. We also know that vaccine uptake with COVID-19 has not been very strong, and waning vaccine immunity also made individuals more susceptible to these new JN.1 family of variants. So those are at least two factors we think that really contributed to the increase in cases this past summer. Historically, meaning the last 3 years for COVID-19. We've also seen a surge of cases in the winter. But perhaps a silver lining in that cloud is that the large number of summer cases may mean that our winter wave is going to be a little bit smaller because individuals infected in the summer will have immunity that should take them through December and into January.
Another question for you, Dr. Pekosz. From Cox Media, Nicole D'Antonio. The CDC reported almost 200 children died from the flu during the 2023-2024 season. That is one of the worst flu seasons on record. A majority of the children had not been vaccinated against influenza. Can you share any advice for parents?
Well, the influenza vaccination guidance given by the CDC and the US FDA is that anyone over the age of 6 months is eligible for influenza vaccination. For children, that's a little bit more challenging because for most children under the age of 8, it's recommended that they get 2 doses of the vaccine spaced out over about 3 weeks. So that's a little bit more challenging to get vaccine into children because of that need for a double dose. But certainly those numbers are reflective of things that we know happen with influenza on an annual basis. Influenza can kill upwards of 25 to sometimes 50,000 individuals in the US every year. And we often focus on those over the age of 65 as being particularly vulnerable to severe influenza, but children are also vulnerable to severe disease and death, as last year's numbers shown. So understanding that vaccines work to limit those severe disease cases even more than they limit the ability to reduce total infections is important to note. And again, it's a recommendation that goes across the entire age spectrum. And again, more individuals should be taking the influenza vaccine than have in the past couple of years.
A question for you, Dr. Debbink. From Yurichiro Inokuchi at Kyoto News, what is the known difference between mpox clade 1A and 1B? 1B seems to cause milder disease, but is there any genomic epidemiological evidence for that? How about the ability to spread between humans?
Yeah, so first let me clarify kind of the groupings of mpox. So there's 2 major groups that we call clades. So you can just think of the word clade as group. So the one that's circulating here in the United States is clade 2, and the one that the public health emergency is referring to are clade 1. And then within clade 1, there is clade 1A and clade 1B that is being referred to in this question. So there has been historically a difference in I guess severity of disease, with clade 1A being historically more severe than clade 1B. But it is really a complicated question because a lot of the data that we have on the severity of these different types of mpox come down to sometimes the health infrastructure in the countries where they're found, and also the background health of the people. So in a country that might have like a lot of people with immunodeficiencies or malnutrition, you may see differences in mortality rates or severe disease that are more due to that than what you would see if it was circulating in a place that had better health infrastructure. I think at this point we don't know a lot about genomically like what the difference would be, or if there are specific genetic elements that would cause more severe disease or less severe disease. So I think that will be definitely an area of active research going forward.
Great, thank you. Oh, go ahead.
I was going to address the second part and the ability to spread between humans.
Please.
Yeah, there's definitely been a difference there. So both in the clade 2 virus that is circulating here and the clade 1B that has spread to many countries, we're seeing a lot more transmission there due to sexual contact, whereas historically it was really more contact within households that was probably just general, interacting with your family and those types of things. So there definitely has been a shift in how we're seeing mpox spread.
Great, thank you. And for you, Dr. Pekosz, from Grace Wade at New Scientist, the CDC is conducting serology testing on healthcare workers who developed respiratory symptoms after contact with a patient in Missouri who had the virus. Has it been long enough for H5N1 antibodies to appear in their blood, saliva, if they had caught it?
Yeah, this is an important question. The H5N1 human case in Missouri did have associated with it several individuals who came up with respiratory symptoms, but were not tested for H5N1. Um, Influenza is really only present in those individuals for a few days. Once you pass that window of time, you have to wait to do something called a serology test, which is where blood is taken from an individual and you test for the presence of antibodies to the virus that you think the person was infected with. Now, the earliest you can do serology is 2 weeks after an exposure, and ideally, you'd like to wait about 28 days after an exposure before you test the blood, because especially the first time a person sees a virus, it oftentimes takes about 4 weeks before a strong antibody response is present in the blood. Testing before that runs the risk of giving a false negative. So um, everybody's anxious about some of those results of the healthcare workers in contact with this patient, but we really have to wait until we hit that 28-day window, and then the tests have to be done very carefully to make sure that we're finding the H5 specific antibodies and not detecting potentially some cross-reactivity with human influenza virus strains. So this is one of those situations where we just have to wait for the tests to be done, given the time needed to get the antibodies high enough and the importance of doing the tests correctly.
Great. A follow-up question on COVID for you, Dr. Pekosz. Nick Iannelli at WTOP, did you say that the COVID vaccines are becoming less effective? I think you said waning immunity. Is that a concern?
The COVID vaccines that are available this fall are a fairly good match to all of the circulating variants of COVID-19. They're never a perfect match because the vaccine strain choices made back in June, and while the vaccine doesn't change, the virus keeps replicating and the virus keeps mutating and the virus keeps changing. But again, for most part, the circulating variants right now are a good match for the COVID-19 vaccine. We do know that the vaccine immunity is really optimal for maybe about 3 months, and after that, it starts to go down and provide less protection. But if you get a COVID-19 vaccine right now, you should be protected well through the expected surge in the fall, and it should recognize the current variants that are circulating.
Okay, for you again, Dr. Pekosz, Eduardo Cuevas at USA Today, regarding H5N1, how concerned are you with healthcare workers in Missouri presenting respiratory symptoms following treatment of the state's first index case who had been hospitalized for bird flu? Are there any state or federal actions you're looking for at this time?
Yeah, most important thing with those healthcare workers is to do this blood test, the serology tests, to see if they actually, in fact, were infected with H5N1. There are respiratory illnesses that are circulating right now. So the fact that these healthcare workers did develop symptoms while caring for the H5N1 patient doesn't necessarily mean that they were infected with H5N1. And in fact, at least one other healthcare worker that had symptoms did test negative for H5. So it's concerning. It would have been ideal to have tested these people while they were symptomatics to see if they were directly infected with H5N1. And it certainly speaks to something that we probably need to be a little bit better on in terms of our ability to do surveillance, to identify these cases, and to test these cases as quickly as possible to make sure that we capture the first evidence of any kind of potential human to human transmission with the H5N1 virus.
Great. And for you, Dr. Debbink, what is your assessment for boosters or updates for mpox vaccine among at-risk Americans? How much should health officials look at distributing vaccines in and around Congo?
Yeah. Yeah, so we have a really good vaccine for mpox. It's a 2-dose vaccine, and so the CDC recommends that those in high risk groups get vaccinated. And I would echo that's very important. And in terms of distributing vaccines more globally, this is like a huge responsibility of the public health agencies worldwide to be providing vaccines to countries where where mpox is both endemic and then where it's spreading. So you know, and there are ongoing efforts to do this. The United States has given resources and money and vaccine doses to mpox endemic countries, and you know, since the public health emergency of international concern from the World Health Organization, there's been additional contributions to that effort.
Great, thank you. For you, Dr. Pekosz, a question from Lisa Colangelo at Newsday. Last year, the COVID-19 vaccine uptake was very low and flu vaccine uptake was also down. What will be the impact this season if very few people get these vaccines? And that was COVID-19 vaccine uptake.
Yeah, but I could also we can lump COVID-19 and influenza vaccine uptake together. In particular, COVID-19 vaccine uptake was incredibly low across the population groups, with the potential exception of those over the age of 65 who had a decent uptake of the vaccine, although not as good as previous vaccines for COVID-19. We also saw a downtick in terms of the number of influenza vaccines that were distributed and taken up last year as well. Some of this, I think, is part of the COVID-19 fatigue that we're experiencing in the population. People want to sort of forget about COVID-19 because they feel the worst of it is over. But this is an important reminder that we now have the tools to limit the number of cases, and in particular, the number of severe cases, to provide protection to those individuals in the high-risk groups for severe disease. And those tools, though, have to be utilized effectively. They have to get off the shelf and get into people's arms so that they can do the job that they were designed to do, which is to reduce cases and to reduce severe disease. So we really have to do a better job of communicating that need to the general public. We know the vaccines are safe. That safety record is a mile long right now, and the COVID-19 vaccines are one of the most studied vaccines ever in the history of humanity. And we just need to find better ways to communicate that to those individuals, particularly in those high-risk groups that would have the greatest benefit from both the COVID-19 and the influenza vaccine.
Great. And a follow-up on that, should people get their flu and COVID shots on the same day in the same arm or spread it out by a week or so?
Yeah, there actually have been studies looking at taking the COVID-19 and the flu vaccine together, and even in the same arm or in different arms. And the bottom line is that it really doesn't matter. It's best to get them both, I think, taken as close as possible to each other, simply because studies have shown that if you go in to get one and say that you'll go in maybe 3 or 4 weeks to get the second, many people actually never go back to the pharmacy to get that second vaccine, whether it be the flu or the COVID. So if you have the opportunity to get one, I would say get both, because right now is a great time to get both of those vaccines. And again, there's no detrimental effects of getting both vaccines on the same day.
Great, thank you. Very helpful. Here's a question for you, Dr. Debbink, from Mary Wenwa at Talk Africa. What would be the general impact to public health when such diseases are now coming in? For example, mpox and others. For example, I am from Kenya in Africa, where most countries have very fragile health systems.
Yeah, so obviously the impact on places that don't have great health infrastructure could be really detrimental when it comes to the spread of mpox and other infectious diseases. This is a big part of why the World Health Organization issued a public health emergency of international concern, so that there would be a global response and global help to dealing with mpox in countries where it's currently circulating, where the health infrastructure might not be that good. So hopefully what's going to happen is that the global community is going to help reduce the burden in those countries, and provide support in those countries to limit the spread of mpox.
Great. And for you, Dr. Pekosz from Tara Hale at the Association of Healthcare Journalists, how concerned are experts that H5N1 still has the potential to kick off another pandemic?
Yeah, H5N1 avian influenza is at the top of the list right now of viruses that public health officials are concerned about in terms of causing a pandemic. Over the past couple of years, there have been more and more cases of H5N1 appearing in mammals. I actually am in Australia right now attending a meeting where we had a large discussion of some of the outbreaks of H5N1 in marine sea mammals, such as sea lions and elephant seals. We've seen H5N1 infections in bears, foxes, and other predatory mammals in the US. And of course, we now see it in dairy cows across the US. When an avian virus enters a mammal, it has the ability to adapt and become better at replicating in those mammals. And again, while humans aren't cows or bears or sea lions, we are mammals and we share some genes that the virus will, if it learns to use them better, it'll make that virus more easy to infect humans. The other issue with dairy cows is it puts the H5N1 virus in close proximity to a large numbers of humans, those dairy cow workers who will have to come into contact with infected cows on an almost daily basis during the milking and care that dairy cows on farms have to do. So H5N1 itself is a dangerous virus. It's now in an animal species that increases the likelihood of humans getting in contact with that virus. All of those things are not good in terms of a virus that has that pandemic potential. So for all those reasons and a few others, there is a high emphasis right now on trying to control this H5N1 outbreak, and particularly as we enter seasonal influenza, um, to try to limit the number of cases in humans so that we don't have that potential for the virus to emerge into the human population.
Great. Here's a follow-up question from Tara for Dr. Debbink. How concerned and/or aware should the public be about parvovirus?
So we didn't talk yet much about parvovirus, but parvovirus is a virus that regularly circulates in the population. It usually happens at pretty low levels, and it's usually in kids or in work situations where people come in contact with kids. In general, it's a pretty mild disease, and people recover just fine. However, in the last year, we've seen a large increase in the cases of parvovirus. And while we still expect most people to recover just fine, it is important for a couple high-risk groups to be aware that that it can cause more severe symptoms or outcomes. So for instance, like in people who are pregnant, it can cause miscarriages or other developmental issues during pregnancy. And then in people with blood disorders, for instance, people with sickle cell disease, it can also cause more severe outcomes. So people in those high-risk categories may want to take additional precautions, like masking or taking additional precautions and interacting with kids who may be showing respiratory virus symptoms. But in general, it usually is a self-resolving disease that is, kind of like more mild in kids.
And if I can add, it's one of those good examples too about a virus that, we don't have a test for, but when your kids in particular show those symptoms of fever and illness, it's just another reminder to make sure that they stay home until their fever has broken, till symptoms have gone away. We have a lot of tests now at home, tests for flu and for COVID. Those are great too, because those help you identify individuals who maybe can get antivirals or treatments. But even for diseases where we don't have treatments, just following that common sense of keep your kids homes, or you yourself should stay at home until your symptoms abate, because that'll help you recover faster. It'll also help reduce the spread of these viruses in the community in general, and protect those high-risk populations, as Dr. Debbink has just said.
Great. And Dr. Pekosz, this is the final question from Susan Morse at HIMSS Healthcare Finance News. What does this flu and virus season mean financially for providers? Will consumers get another COVID shot if it means paying for it?
Well, in the US at least, the recommendations for COVID and flu vaccines, that everybody over the age of 6 months is eligible for that, means that anyone who has health insurance should be able to get a COVID or a flu vaccine at no cost. For individuals that don't have health insurance, that question becomes a little bit more complicated. There are some ways those individuals can get vaccines paid for by the government, but for the most part, that'll be out-of-pocket expenses. And we certainly know that when an individual has to pay out of pocket for a vaccine, the number of people who get those vaccines drops tremendously. But again, for most individuals in the country that who have health insurance, the COVID vaccines and the flu vaccines should be free of charge. Insurance will cover those costs, and there should be no out-of-pocket expenses for those individuals.
Great. Thank you so much. Thank you for your presentations and insightful answers. We will email the links to the resources mentioned today and shared in the chat. And with that, I'd like to say thank you again to everyone for joining us today.